the topic of the presentation is choroid plexus tumors, and I am Dr. Mohammad Rais Anis, Medical Officer, Aziz Bhatti Teaching Hospital, Gujarat. We will study the classification, imaging, and how to diagnose choroid plexus tumor, and then the management of the choroid plexus tumors. So the objective of our study is definition and origin of the choroid plexus tumors, then how WHO 2021 classify these tumors, and then neuroimaging, how to diagnose and what histopathology and immunophenotype grading is required for the diagnosis, then the treatment, the surgical strategy, and the prognosis of these tumors. So what are choroid plexus tumors? These are very rare intraventricular neuroepithelial tumors arising from the epithelium of the choroid plexus. The choroid plexus normally produces CSF, and these tumors retain that secretory capacity as well. Predominantly a disease of young children, most commonly occur in young infants and young children, but may occur at any age. There are 3 WHO grades spanning benign to frankly malignant behavior and account for 0.3 to 0.6% of all intracranial tumor. So it arises from the choroid plexus epithelium, secretes the cerebral spinal fluid, and then the tumor causes increased CSF production and obstruction, and then further causes hydrocephalus, and the patient came with the symptoms of hydrocephalus or increased ICP. So epidemiology, it is 0.3 to 0.6% of all intracranial tumors, all ages, 1 to 4% of all pediatric brain tumors, and 1 per million age standardized incidence. Our peak age is less than 2 years. So peak incidence is in the first year of the life, 6 in per million, rare in adults, less than 1% of the adult brain tumor. So the other graph is showing the subtype frequency of these the subtypes of the choroid plexus tumors. The first one is choroid plexus papilloma. The second is atypical choroid plexus papilloma, and then the choroid plexus carcinoma. The highest frequency is with the choroid plexus papilloma with the 67%, then atypical with 11%, and choroid plexus carcinoma with 21%. So according to WHO classification CNS 5 2021, these are categorized into 3 categories, subtypes. One is papilloma, the choroid plexus papilloma, which is WHO grade 1, then atypical papilloma, which is grade 2, and the carcinoma, which is grade 3. Basically, the grading is assigned on the basis of mitotic activity. In case number in papilloma, these are benign, resemble normal choroid plexus, absent and low mitotic activity. But in case of atypical papilloma, there is intermediate, greater than or 2 mitosis and higher recurrence risk. In malignant anaplasia, there are 5 greater cells of mitosis, which categorize into choroid plexus carcinoma grade 3. So on the basis of mitotic activity, these are graded into papilloma to atypical and atypical to carcinoma. So then come to the location and the distribution. So in children, these are mostly common in the lateral ventricles, usually in the atrium, the trigone, the most common site in the pediatric age group. And in adults, it is most commonly found in the fourth ventricle, the most common location when these tumors present in the adulthood. So the rare sites are the third ventricle, cerebropontine angle, the suprasellar region, and multiple ventricles may be involved. Clinical presentation, patient came with the signs and symptoms of raised ICP, which are headache, vomiting, papilloedema. In infants, microcephaly, bulging fontanelle, irritability, and poor feeding. And hydrocephalus, the dominant presentation in most patients, and less commonly with the seizure and focal deficit, depend upon the tumor location. So why hydrocephalus? Basically, the CSF overproduction by the tumor output can exceed normal, mechanical obstruction of the CSF pathway, plus minus impaired resorption due to hemorrhage and high protein. Basically, these are highly vascular tumors, so they ongoing bleed, so which further causes the arachnoid granulation to difficult to absorb the CSF from that path. Imaging hallmarks, the intraventricular, you can well appreciate the image on the right side. This is axial T2 image, and the other is T1 image. This one is a without contrast, and the other is with contrast. Basically, these are fairly homogeneous contrast enhancement, and on MRI T1 it is mostly iso to hypointense, and on T2 it is iso to hyperintense. Or you can well appreciate some here internal voids which shows the blood supply of these tumors. These are always associated with hydrocephalus. Imaging spectrum, papilloma to carcinoma, uh, the heterogeneity, necrosis, hemorrhage, and irregular margin, and peritumoral edema and brain invasion. These all things favoring the carcinoma. The more aggressive, the more heterogenesis, the more necrosis, and the more irregular margins, which shows this patient has a carcinoma type. So this is a choroid plexus carcinoma example radiology, and this is a most commonly is a choroid plexus papilloma. So the WHO classification 2021 is categorized on the histopathology as well and the immunophenotype as well. So on architecture, these are papillary fronts over the fibrovascular cores. Single layer of cuboidal to columnar epithelium are present. The choroid plexus papilloma closely mimics normal choroid plexus. So grade rises with mitosis, cellularity, pleomorphism, necrosis, and the loss of papillary pattern, which is very specific to the choroid plexus papilloma. Other useful immunocenteins are cytokeratins, vimentin, and S100, the transthyretin, and the prealbumin, which these choroid plexus produce the albumin. These are also the positive in the cases of the choroid plexus papilloma. The KIR 7.1 and steniocatin and relatively specific help separate from metastatic carcinoma and ependyoma. So this is a diagnostic criteria for the first, the benign, the grade 1 papilloma. Essential criteria WHO CNS grade 5 include the choroid plexus differentiation on histology like papillary pattern, and the immunophenotype like we already discussed in the previous slide, absent and low mitotic activity, interventricular and cerebropontine angle location. The location is important, the site is important, the immunotype is important, and the histological important. Then we come to the atypical papilloma, the grade 2. The essential criteria for the atypical papilloma includes the location, which is intraventricular or cerebropontine angle location, the choroid plexus differentiation, histology, and immunophenotype, increased mitosis, which is very important, which differentiate from the typical papilloma from the atypical papilloma, which is greater than 1 millimeter per square, greater than 2 mitosis, and other which does not meet the criteria for the carcinoma, choroid plexus carcinoma, which are greater than 5 mitosis on microscopy. So the essential criteria for the carcinoma includes the choroid plexus differentiation, greater than 4 to 5 malignant features, increased cellularity, nuclear pleomorphism, solid sheet, necrosis, frequent mitosis. In the case of atypical papilloma, which are greater than 2, but in a case of carcinoma, it should be greater than 5 under high magnification microscope. And these are the interventricular location and desirable T553 analysis and methylation profiling, also favorable in case of carcinoma. So the differential diagnosis of the lateral ventricles in child includes after the ependyoma, atypical teratoma, and the CNS embryonal tumor, and the fourth ventricle in a case of adult includes ependyoma, metastasis, subependyoma, and medulloblastoma. Some villous hypertrophy of the choroid plexus, diffuse bilateral enlargement causing CSF overproduction. It also mimic like a papilloma or of the choroid plexus, but on MRI there will be no discrete mass on the MRI. So we can differentiate from that on the basis of MRI. And management strategy includes the maximum safe resection is the mainstay and the strongest prognostic factor, especially for choroid plexus carcinoma. These are highly vascular, so the blood risk, serious blood loss risk is very common in the infants. Approach tailored to the tumor location, like in a case of lateral ventricle, we go for the transcortical or transcloser approach. And in a case of the fourth ventricle, we go for the telovelar or midline suboccipital approach. So the typical surgical pathway includes the MRI with neurexis staging. Then we go for the pre-op embolization in the case of the shrinkage of the tumor, interior choroidal vessels, artery. and then we come to the maximum safe resection and treat residual hydrocephalus with the EVD or shunting. Adjuvant therapies includes in a case of choroid plexus papilloma, the maximum gross total resection is usually curative. Surveillance MRI is required, which will be on the 3rd month and 6th month and the 1 year. And then atypical choroid plexus papilloma, the gross total resection closer follow-up, it will be like 4 weeks and then 2 months and then 6 months. Adjuvant therapy, if incompletely resected and recurrent, GTR plus chemotherapy. In a case of the infants like less than 12 months, we not go for the radiotherapy in that cases. So we go for the chemotherapy first. So these chemotherapy will be given to the infants which are not which have a subtotal resection or any residual symptoms. Lee-Fraumeni syndrome, basically this is strongly linked to the choroid plexus carcinoma. In this syndrome, the tumor suppressor gene P53 is deficient. So in these cases, when we go for the radiotherapy, we have to be conscious in that cases. Basically, radiotherapy also causes the tumor risk. So when we giving the patient the radiotherapy in these cases with these syndromes, there is a higher risk of the malignancy as well. So, and the choroid plexus carcinoma with this syndrome had the worst prognosis as well. So prognosis and the outcome, the 5-year overall survival by grade. So the grade 1 tumors has a very good 5-year overall survival, which is 90%. Atypical is 78%, and the choroid plexus carcinoma has 60%. So the maximum gross total resection is decisive, and the complete resection roughly triples the survival versus subdural, 58% to 20% at 5 years. Two extremes are there. The one extreme is completely resected choroid plexus carcinoma near 100% long-term survival. Then the second extreme is the choroid plexus carcinoma with P53 mutation, markedly worse prognosis. The kids versus adults, we know that there will be a most common location in the children are the lateral ventricles and the fourth ventricle in the adults. Then overproduction of CSF plus mechanical obstruction causes the hydrocephalus, so patient come with the sign and symptoms of hydrocephalus. Then they plan for the significant blood loss, especially in the infant, because these are very highly vascular tumors, so they bleed hell. Then the imaging clue, it is the enhancing on the MRI, and it cauliflower-like type. And on surgery, the gross total maximum resection is the most important prognostic factor. And think genetics. If the choroid plexus carcinoma, consider Lee-Fraumeni, and P53 stage the neurexis. Always scan the neurexis in the case of ependymoma and like in a choroid plexus tumors and medulloblastoma, because there is a higher chances in the cases of these tumors to be the drop mats in the spine as well. So rare epithelial intraventricular tumors of the childhood from CSF producing choroid plexus. The WHO CNS grade 1 already categorized into 3 categories: the papilloma, the atypical papilloma, and the carcinoma. And the imaging, it is enhancing intraventricular mass with hydrocephalus. Carcinoma looks heterogeneous and invasive. Surgery is the cornerstone, the maximum gross total resection, adds chemo plus radiotherapy plus neurexis staging. Prognosis excellent for the choroid plexus papilloma, guarded for choroid plexus carcinoma, and driven by the extent of resection and TP53 status. So these are the references. Mostly references are taken from the Greenberg. Thank you so much. Any questions and suggestions?
How to differentiate, as these tumors are also intraventricular, and some other intraventricular tumors are also there, such as ependymoma. So how to differentiate these tumors from ependymoma on the basis of MRI or any other investigation?
So these are contrast enhancement. So I have already shown that these are heterogeneously enhancing lesions. In the case of subependymoma, in the intraventricle and the choroid cyst, they do not enhance. So if we go for the imaging, so we differentiate on the basis of enhancements. And furthermore, these are also very large lesions when present on MRI, and higher also causes the hydrocephalus as well.
As these tumors are present in the ventricles, most common site, as you said, that it is the atrium of the ventricle. So what may be the surgical approaches for these tumors?
So if there is, we go for the big ventricular tumor in the lateral ventricle, then we go for the transcloser or the transcloser and the interhemispheric approach. Okay, two approaches are there. Either we go for the brain tissue, either we go to the separating the natural corridor in the hemispheric the slats and go to the ventricle in the lateral ventricle. As you already told, these are the common location for the in the lateral ventricles are the atrium. So because the choroid plexus are not there in the frontal and the occipital horns, these are mostly present in the lateral, in the lateral, in the especially in the trigone in the atrium. The most common location for these tumors are the lateral ventricle and specifically in the atrium of the lateral ventricle.
And what if in the fourth ventricle, what may be the surgical approach?
In a case of the fourth ventricle, we go for the two approaches: the telovelar approach or the transvermian approach. But in cases in the transvermian approach, we have to cut down that vermis. But this approach also exposes. But in the case of the telovelar approach, there is a natural corridor. We go through that approach and go to the fourth ventricle,
What is the natural corridor?
telocolida and all that things.
Can you explain the structures which are seen in the telovelar approach?
On this topic,
We will discuss the
surgical approaches
Yes.
that wrong.
I have two questions. Is there any role of neoadjuvant chemotherapy in the choroidal plexus tumors? And the second one is there any role of intraoperative or preoperative shunt efficienting in choroidal plexus tumors?
These are very good questions. First question is that if there is any role of chemotherapy. You can
Neoadjuvant chemotherapy. Neoadjuvant chemotherapy.
add a new adjuvant chemotherapy. And the second is okay, what is the role of shunt in these cases? So first, like in the cases of very young infants, like less than 1 year, okay, 12 months of earlier child has when we go for the radiotherapy in that cases, there is many side effects of that radiotherapy on that cases, neurocognitive side effects and other effects. So we deferred that treatment in the cases of less than 12 months old children. So we go for the chemotherapy instead for that patient. So there is a role of chemotherapy in that cases. So the second question is the shunt. Basically, these are very, I already told that there are very vascular tumors. So when we go for the surgery, they can bleed hell. So when they bleed and we separate the tumor from, resect the tumor, then they bleed, the CSF is tinged with the blood. So they can cause the pathway to obstruct, like when they absorb at the granular tissue, they can be obstruction. So hydrocephalus can occur. In that cases, we put that EVD in that cases, wait for the response, and then clamp for the EVD. And if patient did not develop the hydrocephalus, then we put out the EVD and do not place the shunt in that cases.
AVD preoperatively or intraoperatively?
If the patient comes with the acute hydrocephalus, then we go for the EVD first in the preoperative cases as well. And we also do the EVD in the intraoperative cases as well too. Develop. I will further. Sir will guide further the latest things.
Pre-op EVD, actually we do not go for the pre-op EVD. We do not advise, because if you're gonna put the EVD, we cannot go inside the ventricles because the ventricles would be decompressed.
Compressed.
So the ventricles, they are actually giving us a path to reach till the tumor and remove the tumor. You know, even the post-op EVD is very dangerous, because when you put EVD, you are putting the patient at risk of developing ventriculitis. So we have seen that after removing all of the tumor, you know, there would be oozing, there would be a lot of
Yes.
bleeding over there. So you have to put something over there. So if you're going to put post-op EVD, it is causing a lot of complications. So what I used to do, after excision of the tumor, I wait for the repeat CT scan. If I see that there is a gross hydrocephalus, then I go for the VP shunting. But if there is a blood inside the ventricle, then I put EVD. But I would suggest that you should go for graduated EVD, which is more safe and it's better as compared to the conventional EVD that we are going for that.
Yes, sir.
Removal of the tumor is not something very difficult, but managing the post-op hydro is
Yes,
very
yes,
difficult.
sir.
You know, We can go for that. Yes, we can go for that. Yes,
Up-
you are absolutely right. If you have the facility for that, you should go. Because if there is no bleeding, the tumor, we can easily excise the tumor and there would be less chances of developing post-op collection
Collect.
inside the ventricles.
Exactly, sir.
So it is the blood. If there is no blood, we can easily put a shunt. But when there is a blood, we have to put EVD.
Yes, sir.
And EVD has a lot of complications. In many cases, we have seen in the ward and everywhere, EVD is with lot of risks.
Yes, sir.
Otherwise, it was a very good presentation. Especially another thing that you have added in your presentation is the references.
Yes.
So there should be a slide at the end. We should tell that what were the different kind of references over there.
Yes, sir.
So your presentation is always very good. You are looking very smart as well
Oh, thank you,
with,
sir.
with your new overall. So I mean,
Thank you, sir.
it's really a very good thing.
Thank you, sir.
Any other question, please? Okay, keep it up.
Thank you. Thank you, sir. Thank you.